Pediatric Low-Grade Glioma. So my name is Jillian Demas, Senior Program Manager here at the American Brain Tumor Association, and I am delighted to introduce our speaker today, Dr. Peter Manley. Peter Manley is the Director of the Pediatric Brain Tumor Survivorship Clinic at the Dana-Farber Boston Children's Cancer and Blood Disorders Center. His research interests include long-term effects of treatment on brain tumor patients, specifically in fatigue, sleep, and obesity. Thank you so much for joining us, Dr. Manley. You may now begin your presentation.
Thank you very much, Jillian, and I appreciate having the opportunity to speak to you today. Again, my name is Peter Manley. I'm at the Dana-Farber Children's Hospital Center for Cancer and Blood Disorders, and I'm going to talk to you today about low-grade gliomas. We're going to talk about advances in diagnosis, treatment, and outcomes, and I look forward to hearing your questions after I'm done with my talk, and I made it a little bit on the shorter side because I know that there will be a lot of questions, and feel free to ask anything. Just to go over, before we give any talks, we want to disclose if we have any relationships with any pharmaceutical companies, and I just have some trial support from a company called Sanofi. But other than that, there's no other personal financial conflicts. So what we're going to do today is we're going to look at how, as parents or and caregivers, we evaluate the treatment options for treating low-grade gliomas. That would include surgery, chemotherapy, targeted agents, and radiation. And then also understand the long-term outcome of pediatric low-grade gliomas, and knowing this, can this influence our choice of how we will choose therapy and what the outcomes would be based on the choices we make. So just a brief overview of brain tumors in general. Brain tumors have an incidence of about 3 in 100,000 children. This is pediatrics again. It has gone up slightly, but that's probably most likely due to improved diagnostic imaging that we have utilized now. So we do diagnose some children who have head trauma, and we find a brain tumor that's a low-grade glioma, and usually those children do very well, but they still get categorized as a brain tumor, so numbers have increased slightly. But the most common time that we see this is usually under the age of 10. Boys maybe a little bit higher than girls, and there's no racial predominance in terms of who gets a brain tumor. It's equally distributed across all ethnicities. So if you look at all the different types of pediatric cancers that we have, the most common is leukemia, but not far behind are brain tumors. So brain tumors are what we call the most common solid tumor in children. So there are about 12,500 new cases of pediatric cancers per year. So we see about 3,000 to 4,000 in the United States per year. And at our center, we're one of the larger centers in the United States, and we see about 100 to 125 cases per year. And it may not seem like a lot, but pediatric cancer compared to adult cancer is much less common. And then if we break it down even further and look at all the different types of brain tumors there are, you can see that low-grade gliomas or low-grade astrocytomas are the most common brain tumor in pediatrics, which is a good thing because most children with low-grade gliomas do quite well. Whereas the adults, they tend to have these high-grade gliomas here. They are much more common in the adult population. So when we talk about low-grade gliomas, what are we talking about? And you'll hear sometimes that I'll go back and forth between low-grade gliomas and low-grade astrocytomas. So a glioma is the cell of origin that it arises from, and within gliomas, there are different cell types. So we see here there's a glial cell called an astrocyte. So this is the most common type that we see, which is an astrocytoma. And we divide these into multiple grades. So a low-grade glioma can be a grade 1 or a pilocytic astrocytoma, a grade 2, which is a fibrillary or diffuse infiltrating astrocytoma. You'll also hear some newer entities called a pilomyxoid astrocytoma. And sometimes we can not classify it specifically as a pilocytic or fibrillary, so they'll just be classified as a low-grade glioma. If you get a tumor from oligodendrocytes, which is another type of cell, these will also be called oligodendrogliomas. These are much less common in pediatrics and occur more in the adult population. In addition, we'll sometimes call an astrocytoma or low-grade glioma by the place we find it. So if it's in the nerves of the eyes, we'll call it an optic pathway glioma. Sorry, there's a little typo there. That should say hypothalamic glioma. We'll also, if it's in the back part of the brain, we'll call it a posterior fossa pilocytic astrocytoma. If it's sitting right on top of the brainstem, you'll hear this sometimes called a tectal glioma. And then there are a wide variety of different types of tumors that all are classified as low-grade gliomas, but as we learn more and more about low-grade tumors, we can separate them even further. So how do we diagnose them? We're still using technology that's been around for a while, and that's looking at these tumors under a microscope. So when a tumor is removed from the brain, we take it and we freeze it, and we also fix it in some wax, and then take some small slices and stain it with different materials that help us diagnose a low-grade glioma. And this is what we've been using for the last few hundred years. I will show you that we're moving a little bit further beyond just the microscope, and we're learning more about these tumors on a molecular level, and I'll talk about that a little bit later. So as I said before, there's lots of different gradings of low-grade gliomas that range from these grade 1s, which are very slow growing, to these oligodendrogliomas, or PXAs, which stand for pleomorphic xanthoastrocytomas, which can be a little more fast growing, but they all seem to act similarly overall in a long-term outcome. In addition, low-grade gliomas can occur anywhere in the brain, and they can look a lot different depending on where they are. So this is a low-grade glioma in the back part of the brain called the posterior fossa. This is the most common place that we see low-grade tumors. This is a posterior fossa juvenile pilocytic astrocytoma, or grade 1. This is a hypothalamic optic pathway tumor, and you can see that this looks a lot worse than this tumor here. This can cause more symptoms with regards to vision loss and endocrine function. These patients will usually present with balance issues and headaches. So even though they are classified under the same category as low-grade astrocytomas, they can look completely different. And depending on where they occur, can also be much more difficult to take out. So for instance, this tumor here from a surgical standpoint might be a little bit easier to remove than this tumor here, because it's attached to the optic nerves and the pituitary gland, and there can be a lot more morbidity from a surgical procedure. This is what a tumor looks like under the microscope here. It's not very cellular. If you go to a higher magnification here, if you have a very aggressive tumor, all the cells are packed together. The cell is this little dark blue dot, so you'd see thousands of these all next to each other if this was a very aggressive tumor. This is what a low-grade astrocytoma typically looks like. And this biphasic pattern is just how, when they smear it across the slide, how it looks. And a Rosenthal fiber, just in case people are wondering, is just a, if you've had a tumor for a long time, these things form and just are much more indicative of a slow-growing process than a fast-growing process. So how do we diagnose pediatric brain tumors? The first thing we use is an MRI scan. Some children have CAT scans or CT scans. CAT scans are not great at looking at tumor tissue. They're really good at looking for hydrocephalus or increased pressure in the brain because the spinal fluid's not draining properly. It's good at looking for blood. It's good at looking at bone. So if you have a fracture, you can sometimes see tissue injury in that respect. But an MRI really gives us the best definition of a tumor and where it is. Also, CT scans, you cannot see the back part of the brain very well because the bone obscures that area. With MRIs, it does not. The nice thing about MRI is there is no radiation associated with it. With a CAT scan, there is. And I know we're trying to avoid as much radiation in children as possible, and so we limit the number of CT scans and X-rays, where MRIs do not have any of that. It's a magnetic field and a big magnet that you're in. And again, the bone does not obscure the posterior fossa. And so how do we treat brain tumors? We usually use a multimodal approach. We sometimes use surgery depending on the location. Radiation we have used in the past, although I'll explain a little bit later why we're trying to move away from that. And then chemotherapy as well. And chemotherapies can include these new molecular targeted therapies, as they are usually systemic treatments. And when we talk about chemotherapy, we talk about systemic therapy where you either take something orally or you get something injected into your bloodstream that will go all over and cover every area of the cerebral the CNS axis, or the brain and the spine. So what have we done in terms of neurosurgical advances? So there's a lot that's been improved in neurosurgical techniques. When you're in the operating room, they can really look and see at where your tumor is with a dissecting microscope. There's something called a cavitron, which basically can liquefy a tumor, and you don't need such a large incision to remove it. They usually don't take out tissue in a big chunk. They'll take out enough tissue to get a diagnosis for pathology, and then a lot of times they'll liquefy it with an ultrasonic aspirator. We also have an MR operating suite, which I'll show you what that means in just a second. And then also there's MR and CT guided biopsies. So sometimes when a child has a large tumor that we don't feel can be taken out completely, but we want to get tissue, this neurosurgeon utilizes a computer-aided guidance system that they use from an MRI that's been done of the patient. And in the operating room, that MRI is loaded into a computer system, and they can tell exactly where their biopsy will go, and that way they maximize the effect of where the biopsy will and getting the appropriate tissue needed to make the diagnosis. This is what I was talking about in terms of an intraoperative OR. So this is someone who's having surgery on a brain tumor, which is right here. You can see here that the skull is open, and this, just to show what's going on, this is the neurosurgeon's finger. What this allows the surgeon to do is once they remove this tumor here, they can have the child go back into the MRI scan while they're still under anesthesia, while they're still under surgery, so the skull remains open. They do an MRI scan to make sure that all the tumor, if the goal is to remove all the tumor, that all the tumor has been removed. And right here, say they left a small amount behind, say they left a little bit behind. Prior to doing this, the child would go back upstairs, be woken up, their skull would be closed, their skin would be sutured. They would go for an MRI about 24 hours after their surgery, and if there was a little bit left behind, sometimes the surgeon would then have to have them go through an additional surgery, which means more anesthesia. You have to have your skull opened up again, whereas this allows the surgeon to see if they removed as much tumor as they feel is possible, and sometimes allows them to go back without having to wake up, go back to the ICU, and do an MRI scan at that time. So this has really benefited children to allow a maximal surgical resection without significant issues going back to the operating room a second or third time. In addition, we can do computer imaging where we can see where the nerves are and where the tumor is in relation to the nerves. So this green part here is the tumor. The blue is the ventricles, that's where your spinal fluid is. The red, obviously, are the blood vessels, and the yellow are the nerves that run through this area of the brain. So the surgeon can see where the nerves are running through this part of the brain and see whether or not they would be able to resect this completely. Sometimes the tumor will push nerves aside and the tumor can be resected. If it's in between nerves and just diffusely infiltrating, they sometimes would only resect some tissue. For low-grade gliomas, yes, you can, if you can get a maximal resection, that is optimal. But because we know that children do well, we do not want significant morbidities from surgery, so our surgeons know if they cannot take it out completely without causing significant damage to the child, we do not recommend that that's done. But this imaging can sometimes help guide the surgeon into where the tumor is in location to some very delicate structures within the brain. So what happens in neurosurgery? So obviously, we feel the experience of the neurosurgeon is very important. There are excellent neurosurgeons all over the country, pediatric neurosurgeons who specialize in cancer and oncologic surgery, and that's something we always want the best surgeon possible to operate on the child. We're not saying we have the best surgeons here. They're, like I said, they're great surgeons all over the United States, but you do want to know how many times a surgeon has operated on a patient with a low-grade glioma. Obviously, the location of the lesion is very important. As I showed you before, if it's in a very delicate or deep structure of the brain, then we don't necessarily want the whole tumor removed because other therapies can shrink that tumor. We obviously would talk with the surgeons about how the degree of resection they would take. Obviously, the age of the patient is very important. Young children, the surgeon doesn't have a lot of space to work. So we don't want a young child to undergo a major resection if we think it's going to cause a lot of morbidity. And also we want to know how they are prior to the surgery. If they have significant issues prior to the surgery that is not a result of the tumor, we obviously don't want to make those worse. In addition to that, if a patient is completely functional prior to going to the operating room, we obviously want them to come back completely functional after going to the operating room. So we don't want to cause more problems than are there. So radiation therapy, and I'll talk a little bit more about this as we move forward. This is actually used to be the gold standard for the treatment of low-grade gliomas. And we do know it's effective, and we know it works well on treating low-grade gliomas. However, there are significant issues that are associated with the long-term toxicities of radiation. So when you're giving radiation to a developing brain, you can cause neurocognitive dysfunction. So that's how you think, how you remember things, how you process your language. So the younger you are, the more risk you are for having neurocognitive deficits if you get radiation. We try to, in all brain tumors, we try to avoid any radiation under the age of 3, but in low-grade gliomas, if we can avoid radiation completely, we do. It can also cause secondary malignancies. So if you get radiation, 10 years later, you're at risk for other types of tumors, such as a high-grade glioma called glioblastoma, or another type of tumor called a meningioma. Patients who also receive radiation to areas where there's lots of blood vessels, so usually those are in the midline structures of the brain, are at risk for stenosis of those vessels, and that can cause strokes. That also happens much later. And then also if you have other comorbidities such as obesity, which can go along with the brain tumor, high cholesterol, that puts you at even higher risks. Right behind the nerves of your eyes is a gland called the pituitary gland, and if that gets radiation, you can have hormone deficiencies such as thyroid deficiency, growth hormone deficiency, difficulty going through puberty. And the nice thing though is if you do have hormone issues, we can replace everything the pituitary does. That does require lifelong replacement, and the patient will be on medication for their entire life. If we ever irradiate the spine, that's actually what gives you most of your truncal or chest growth when you get older. So if you radiate the spine, you'll have a shorter trunk and longer legs. So again, what we do before we discuss radiation is how old are they, where is the tumor, and what will be exposed if you give radiation, and what's the dose of radiation going to be to that child. So other types of treatment that we do, we had talked about watching. So if someone has a gross total resection or even a near total resection where the tumor is completely removed or there's just a small amount left, we'll sometimes recommend observation. If you have a tumor removed completely, then that's the standard of care. You would just have the tumor watched with frequent MRI scans for the first year. Radiation we just discussed, and then chemotherapy is the next thing that we'll talk about. These are kind of the older regimens, vincristine and carboplatin. Dr. Packer from Washington, D.C., D.C. Children's Hospital, published on this in 1993, and looked at children who received this therapy. There's a group in San Francisco at UCSF who utilized this medication called TPCV, which is 4 medications, 6-TG, procarbazine, CCNU, and vincristine. And then other regimens such as monthly carboplatin and vincristine and actinomycin D. There are also other therapies that have been utilized in low-grade gliomas, drugs like vinblastine and some newer drugs like Avastin. And so how did these children do? So if you look at this, this is what we call a Kaplan-Meier curve. And when I mean event-free survival here, these are the patients who received vincristine and carboplatin and TPCV. So regimen A is vincristine and carboplatin. Regimen B is TPCV. Why is this curve here? These are for children with neurofibromatosis. So this is a cancer predisposition syndrome where children who have this disease have an increased risk of low-grade gliomas. If you give them TPCV, they're at risk for much higher risk for secondary malignancy, so they all got vincristine and carboplatin. I know it looks like there's a big difference between A and B, but statistically there really isn't. So essentially these two regimens were deemed equivalent. Regimen B did a little bit better, but not statistically significant in that respect. There is a much bigger difference between if you got vincristine carbo and didn't have NF1 or if you did. So what does this mean by event-free survival? This means that children who had this drug, whether or not they recurred. So it doesn't mean that they've died, it means if they've recurred. So most children, if they recur, it's about a 50-50 chance, recur about 3 years from the start of therapy. So why is that important to us? Well, we also know that if you get chemotherapy, you still have a very good chance of survival, and the overall survival of these children are 90+%. Remember, about 50% don't require additional treatment, so that's a good thing. And these children can still respond even if they recur 3 years later, even sometimes to the exact same regimen, or we might switch to a different regimen, such as if they had TPCV, we'll give vincristine carboplatin, or if they had vincristine carboplatin, receive TPCV. And then, and with some of the newer therapies, which I'll get to, they can receive that treatment as well. So what are the future directions? So we talked about the fact that we look at these tumors under a microscope, but now we're actually going a little bit deeper than just looking at them under a microscope. We're looking at the DNA. And then once we look at the DNA, we can learn about the abnormalities within the tumor itself, and then we can think of medications that can potentially help these children just based on what their molecular signature is. Because tumors can look very similar under a microscope, but from a molecular level they can look a lot different. And even though they might have a low-grade glioma, they might have completely different molecular abnormalities that would require completely different treatment. And so luckily, this is what we call a heat map that looks at the abnormalities within a tumor. So these are chromosomes. When you see the little red spots, that's where the abnormalities are. So, and you can see here there's not a lot of red, or there's not a lot of blue. That means there's abnormality. So this spot right here is one of the abnormalities that we've seen in a gene called BRAF. The nice thing is it's a fairly quiet genome in terms of all the mutations in low-grade glioma. If I show you what ovarian cancer looks like in terms of all the mutations, you can see there's a much bigger difference between low-grade gliomas and ovarian cancer. Problem with tumors like this that have all these abnormalities in their genome is you don't know which is the thing that is driving the tumor to grow. There can be thousands of abnormalities, but only one little needle in a haystack is what's causing the tumor to grow. Luckily, we found out that this is what's part of a driving force behind tumor growth. And so this is the pathway that people who have low-grade gliomas in pediatrics should become very familiar with, because there are a lot of medications that are being targeted to this pathway. So this is what we call the RAS-RAF pathway. If you have neurofibromatosis here, this is what turns off this protein here called RAS. If you have a low-grade glioma without NF, you can have an abnormality in this protein here called RAF, or I should say gene called RAF. And then these are the other signals, and this goes all the way down to this target called mTOR, which then tells the cell to keep growing. So if this pathway is always on, it's going to tell the cell keep growing, keep growing, keep growing, and that's what develops a tumor. And then these are just where the BRAF is. This is called the BRAF duplication, and then there's also a BRAF mutation. So I'll just talk briefly about BRAF just so you understand this a little bit better and what happens. So this is a protein called RAF, which then activates this right below it called MEK. Normally when it's not active, it's a single entity. What happens when it activates is it pairs up with something. So it pairs up with itself, so it doubles up in RAF, and that's what activates MEK. If this is single, it doesn't work. In patients who have gangliogliomas or grade 2 astrocytomas, they tend to have a mutation called a V600E mutation, which makes this monomer or single protein act very, very active, and it doesn't need to double up to be very active. In patients who have a duplication, they always have the two rafts together, so they're also constitutively on. So this is what we see in juvenile pilocytic astrocytomas, and this is what we see in low-grade gliomas, and in gangliogliomas and grade 2 astrocytomas. So I'm going to come back to this a little bit because this will influence what kind of treatment we want to give them. So right now there are two studies going on looking at these two pathways. One is called dabrafenib, and there are a couple of other drugs that target specifically this V600E mutation in RAF. And there's currently studies going on here and at some other centers in a phase 1 trial in pediatrics, and also in the adult population they're utilizing this drug as well. So this works in patients who have this V600E mutation. Here's the problem though. So the question some people always ask is, well, does it even matter if I know what the V600E status is of my child's tumor? Can't we just give this medication? So here's the problem in that. If we don't know what your molecular status is, and we take a V600E in someone who has a duplication, sorry, I don't know why that keeps happening. If we just block one spot right here, this actually speeds up even further. And the drug, the V600E mutation drug, doesn't always block every single duplication of RAF. This can then cause the tumor to start growing. So there was a case where they used a treatment using a drug called sorafenib, which without knowing the status of the tumor, and they had to shut it down early because the tumors grew. So if we give someone a V600E drug and the patient has a known duplication and not the V600E mutation, their tumors could grow much faster than they had previously. So that's why we can only give it to patients who have this. So that's why then we're also going to be opening a trial using a drug that inhibits one downstream from RAF. So basically what's happening here is the accelerator is right here to cause the tumor to grow, and we're putting a big brake right here. So this is an accelerator, this is where we're braking it, so it can't move past this spot right here down this pathway to then cause the tumor to grow. So in patients who have the duplication, we utilize the MEK drug first before we'd even think of using this. There is some thought of combining them, or even potentially, could you use a MEK drug for a V600E? Yes, you could. But if you have a duplication, we don't want to give this drug, so that's very important. And so we will never give this drug to someone unless we know their molecular status. So if your child did not have a biopsy, you cannot find this out. And so we would not utilize that medication. Now I'm going to talk about an area right here. So basically people are thinking, well, if this is where the abnormality is, why don't we block it right at the very bottom before it allows the signals to tell whether or not the tumor should grow or to stop growing? So this is a drug that inhibits that mTOR pathway. And there are patients who do have an abnormality right above that called tuberous sclerosis, where they do develop these brain tumors, and we give them an mTOR inhibitor, and you can see their tumors shrink, and then if we stop it, they can grow back, and if we give it again, it can shrink. We also have tried this mTOR inhibitor on patients without tuberous sclerosis, and we have seen effects in children with neurofibromatosis and children who have progressive low-grade glioma. So this is another option. The nice thing about these medications is they're all oral. So you can take take them by mouth, or they have turned them into a liquid formulation if you're younger. So what's next? So you can see there's multiple places to target. There can be some feedbacks into this pathway. So the thought is, can you block both pathways? So we have tried to block RAS. We're blocking RAF. We can block MEK. We can block mTOR. There's some new drugs that will come out here that will block this protein as well to prevent any feedback. And then looking at this complex here. So there are lots of new treatments coming out for patients with low-grade gliomas that this pathway is significantly involved. So that's looking very bright. And we have seen decent responses from these treatments. So the other thing people always ask is, how's my child going to do? If you get on the internet right after your child is diagnosed with a low-grade glioma, I have a lot of parents who come and see me and are very disturbed because they just type in low-grade glioma. And remember, adults get low-grade gliomas too, and the outcomes are much, much different in pediatrics than adults. And unfortunately, if you type in low-grade gliomas, you usually see a lot of adult data. So here at Dana-Farber, we undertook a project where we decided to look at all the low-grade gliomas that were diagnosed in the United States. There's a program called the Surveillance, Epidemiology, and End Results, which kind of gives a snapshot of different areas around the U.S., and that gets all put in a database that's maintained by the National Institute of Health. And we looked at this SEER database from 1973 to 2008, so 35 years of diagnosis. And we looked at your age, your race, where the tumor was, whether or not you had radiation, when you were diagnosed, whether or not you had a full biopsy, gross total resection, or a subtotal resection, and what grade the tumor was, looking at only low-grade gliomas. So we took grade 2 and less, and we found 4,000 patients. And this is just a very busy slide about where it was, so about equal boys and girls. The most common was this pilocytic astrocytoma. The most common places were in the top of the brain or in the cerebellum, in the back part of the brain. You can see the majority of patients either had a subtotal resection or a gross total, with some receiving even no resection. And about 80% actually did not have radiation, and 736 did. And you can see out of this, there were only 10% deaths from pediatric low-grade gliomas, which is actually good. So if we look at that same kind of survival curve, and we look at pediatric low-grade gliomas, and then we did a search for patients above 19 years of age, you can see what the outcomes are in patients who have pediatric low-grade gliomas versus adult low-grade gliomas. And this is very important to recognize, and that these are two different entities. Even though they might look the same under a microscope, we know molecularly they are different. And so these tumors in adults, unfortunately, usually transform and become something more aggressive, where in pediatrics they usually don't. And the majority of deaths usually, unfortunately, if they do occur at the beginning. And then if we took all low-grade gliomas compared to adults, you can see there's a much bigger difference. It's about 88% in pediatrics in terms of survival, and in adults it's about 25%. And if we only focus on the grade 1 and grade 2, it's even better. It's about 90+% survive compared to the adults, which are much less, also in the 40% range. And then we took all the different types of tumors that were listed. So here's a pilocytic, so this is the grade 1 astrocytoma. And here the survival rates are well over 90%. And the grade 2s are still very, the survivals are still very good, well over about 80%, so well over compared to the adult population. And then this was the most interesting thing that we found. So then we divided it up looking at whether or not they had surgery and whether or not they had radiation. And the black lines right here are patients who had a subtotal resection, who had no radiation. Sorry, the black lines are no radiation. The red lines are radiation. So this is very interesting. So you can see it didn't really matter if you had a subtotal resection, unknown resection, or a gross total resection. If you didn't have radiation, you all kind of grouped together, and you all got, your survival rates were still well into the 90+% range. If you had a gross total resection and radiation, or a subtotal resection and radiation, or unknown, you also kind of grouped down into the 75% range. So this kind of showed us, even though people feel that radiation, you do very well from a short-term standpoint, we've shown here that even as you go further out, your chances of dying are much higher if you receive radiation, regardless of what kind of resection you had. So this kind of really showed us that we need to really think about what kind of treatment we need to give these patients, knowing that the chances are quite good that they're going to be long-term survivors. And it was very interesting. So this is an American database, and we just came back from a large international pediatric neuro-oncology conference, and a group in Canada looked at a similar database, only obviously with Canadian patients, and found the exact same thing. So it was reproducible, not just in our population, but in a Canadian population as well. So this was very fascinating. And then we look at what happens after you become much older. So these are patients, how did patients do after the age of 23? We were hoping that this would be a straight line right across 100%. For some reason, there are some deaths. We have to investigate this a little further. But you can see here that the chance of dying after you get older or go past the age of 23 is even lower. This was about 95%, 96%. And so that tells us, too, that these tumors usually don't transform. They don't turn into something more aggressive. So again, we know these patients are going to survive well into their 20s and 30s. And so we have to think of therapies that are going to keep them alive and productive. And the other thing, just to note about this, is we were talking earlier about chemotherapy and why we use chemotherapy. The thought is, too, is if we get you to an adult age, over the age of 20, we feel that these tumors shut down and they don't continue to grow. And this is another area of active research in trying to understand developmental genes in a pediatric brain, and maybe they turn off and don't allow the tumor to grow any further. So the feeling, too, is if we can give chemotherapy until this tumor just turns itself off, we can avoid some other toxicities as well. And so these are the things that we were concerned about in terms of causing disease. So if you had radiation, you were much higher risk of death. If you were younger when you got diagnosed, you are a little bit higher risk. But you can see here that even death from causes that weren't disease-related, whether it's stroke or other causes, radiation really puts you at significant increased risk for dying either of tumor or of non-tumor related causes. So this is a very important thing that we've kind of been talking about here at Dana-Farber for a while, and that we do not utilize radiation to treat low-grade gliomas unless absolutely necessary. And that's what we're talking about with this cost of a cure. So if you do receive radiation, you are at increased risk for secondary malignancies, strokes, poor bone growth, cognitive deficits, and hormone abnormalities. And so that's why we try to avoid radiation, because of these secondary effects, and then just based on this, we would not want to give radiation to a child because it also increases their risk of death. And knowing that children don't die, they survive well into their 20s and 30s, and your chances of dying go down even further as you get older, we do not want to cause the death of a patient by giving them therapy that increases that risk. So just a summary, we have to balance efficacy with long-term toxicity. So obviously we need to utilize therapies that we feel will benefit the child in terms of their treatment. We feel that we want to minimize long-term toxicity because we know they're going to live into their 20s and 30s, and we hopefully obviously much longer than that. Chemotherapy is effective, so when we use chemotherapy, we do tell families that you might need more than one treatment. So sometimes you need chemotherapy and then 3 years later need something else. But the reason we're doing that is because we want to give you therapies that will not cause long-term toxicities. So then the goal of chemotherapy is to get patients into their 20s, and we feel that biology will take care of the rest. So again, surgery is very important. If you can resect it completely, it's often curative. Radiation is effective, and we're not saying we never use radiation. Sometimes you do need to use it. But you have to recognize the severe long-term toxicities and outcomes associated with radiation. Again, chemotherapy is less effective but much lower long-term toxicity. And then we know that patients who have a low-grade glioma as children have a low mortality, and it decreases even further once they reach adulthood. Patients who receive radiation, again, have an increase in mortality, and we have to think about what drugs we're choosing. And hopefully as patients as we learn more and more about the molecular status of patients, we can use targeted treatments that will even minimize the effects of chemotherapy. So those drugs are fairly new, so we're learning a little bit more about them. We do have a long history with some of the other drugs like vincristine and carboplatin. So most treatments right now will start with something like vincristine and carboplatin before moving to the targeted therapies. So when a child is diagnosed with a recurrence or progression, you want to be at a medical center that specializes in pediatric cancer and that have a good understanding of pediatric low-grade astrocytomas. Never feel bad about getting a second opinion. You know, we're one of the larger centers in the country, and patients come here and ask for second opinions, and that's fine. You need to know what's best for your child, and then treatment usually can be provided locally, but sometimes expertise is needed from an outside institution. Not saying us, but anybody else that might have a little more expertise in that area. And then I'll close by saying thank you very much for allowing me to give this talk to you. And if you do need additional information, we do have a couple of websites here at the Brain Tumor Center at Dana-Farber. Those are the websites for that center that give you a lot of our information. And also, if you have any questions, you can contact us directly, and it also has a lot of information just about a variety of different brain tumors. So with that, I will say thank you. I hope this was educational for you, and I look forward to hearing your questions.
Wonderful. Thank you so much, Dr. Manley. That was amazing. And as we spoke about earlier, you are correct. Questions are flooding in. So thank you for leaving so much time. So we'll get right into it. First question, I have read statistics online for PMA, and the outcome isn't great, but it's difficult to find anything up to date. What is your experience of children surviving that type of tumor?
So PMA?
Yes,
or
that's
JPA?
Right. They wrote PMA, but...
So I'm not 100% sure exactly what you mean from a PMA.
Okay, we can come back to it, and
yeah, they could specify that.
Okay, they can re-specify it, and I'll read another question to you right now. The next one is, do you perform fMRIs on pediatric patients, and what software do you use for fMRI and the neuronavigational system?
So we use BrainLab for neuronavigational system for the surgeons. I'm not a radiologist, so I'm not 100% sure about software for fMRI. We'll only use fMRI if we feel that it will benefit a surgical resection or if we're close to areas that are concerning for damage during a surgical procedure or radiation. fMRI isn't that helpful to us in terms of diagnosis, so we don't usually use it for diagnosis, but we do use it if we feel we're near an area that could be damaged in a surgical procedure.
Perfect. Can you talk about proton radiation in regards to LGG, low-grade gliomas?
So proton radiation is a little bit different. And what proton radiation is compared to standard radiation, which is referred to as photons, is that protons have a mass, and so there is no exit dose. So when you're giving someone radiation, you're passing it through the head. If you have photon radiation, you make sure the beams all focus in the area of the tumor, but then those separate beams will come out. So in someone who has a posterior fossa mass, if they get photon radiation, they'll get some exposure to the front part of their brain and their eyes and their throat and their, depending on where the tumor is. Protons prevent that exit dose. However, they still carry all the same toxicities that standard radiation does. So there's no difference between photons and protons except maybe decreasing the exposure to other parts of the brain. But you're still at risk for secondary malignancies. If you still radiate areas that are near vessels, you're still at risk for strokes. If you radiate parts of the cortex, you're still at risk for cognitive deficits. But the hope is that with protons, you will have less exposure. So we still consider it radiation, so we don't usually recommend protons or photons for a low-grade glioma unless absolutely necessary.
Great. And the other woman on the webinar clarified by PMA, she meant
Myxoid. Okay, sorry.
Thank you.
Yeah, okay. So pylomyxoid tumors usually occur in younger children, and they're usually in the hypothalamic region. They are a fairly new entity in that they just were kind of described maybe 10 plus years ago. The feeling is the outcomes maybe are a little bit worse than than juvenile pilocytic astrocytomas or grade 1s. And because of their location, they're usually not as easy to resect because they're usually in the deep mid-structures of the brain. So they can be associated with more morbidities in terms of surgery and treatment. But I've treated a number of kids with pilomyxoid astrocytomas, and they've all survived. So I think because it's a fairly new described entity, we still need a little bit more time. But if you remember my slide here, this slide here, even in the astrocytomas not otherwise specified, which might be some of those tumors or glioma not otherwise specified or variants, you can still see that these did well. So the lowest were these, and they're still 75+%. So, if they weren't diagnosed as pilomyxoids back in the 80s and 90s, they might be under glioma not otherwise specified. So you can still see all of these tumors the patients still do well. And usually if it does cause problems, it causes problems at the very beginning.
Okay. What about long-term survival for, you're going to have to help me out again here, fibrillary astrocytoma?
So again, fibrillary astrocytomas fall in right here, so there's still long-term outcomes, 400+ months of 80%. So they still do quite well. And then so the pilocytics tend to do the best, and the fibrillaries do the worst. We actually just looked at fibrillary astrocytomas only, and again found the same. If we break it down just to fibrillary astrocytomas, this slide still holds fairly true that if you didn't have radiation, you did a little bit better, and it was independent of whether or not you had it removed completely or not. And so the survival rates are still well into the 80%, and it's still held true long-term too. So if you got into your 20s, your chance of dying from a fibrillary or a grade 2 astrocytoma went down. So you did well.
Good. This is interesting because most of the phone calls I get about latest side effects are for radiation. Someone's asking that they've heard that perhaps chemotherapy might cause late side effects. Should a parent be worried about how chemo might cause these late side effects into adulthood?
Yes, so there are risks associated with chemotherapy. We talked about that therapy called TPCV. So there are two drugs in there. One is called procarbazine and one is called CCNU. They're in the family of alkylator drugs, and another drug that some people might have heard of, temozolomide, or alkylators. There is a risk associated with secondary tumors, secondary cancers, usually leukemias associated with that. It's lower than radiation, but it is still present, and if you develop a secondary leukemia, it's 100%. So there is that risk, and then also procarbazine in boys can cause infertility, and so there is that risk as well. So we know it's effective, but we also tend to stay away a little bit from that because some of the newer drugs that are coming out will lean more towards those, such as vinblastine or Avastin. The vincristine and carboplatin, which has been out for a while, does not really have any significant long-term toxicities. There are risks associated with hearing loss, but the doses are very low, and so we usually don't see hearing loss associated with those agents.
Okay. What treatments are used to increase the percentage survival if the patient had radiation, and what is the percentage of survival probability after the 23rd birthday if they did take radiation?
So we're going to look at that a little more in depth, so I don't have a perfect answer for you there. If you look here, the survival with radiation after 20 years from diagnosis, so if you're 2 or 3, you're at that age, is still about 70%. So you still do fairly well compared to the adults, which will be way down in this range, in the 30% range. Once you have radiation, there's really nothing you can do to improve, to make any differences. Unfortunately, when it's done, it's done. But you just need to be aware of any changes in a physical exam or any symptoms that could be associated with a secondary tumor. The most common type of tumor are meningiomas. They tend to grow fairly slowly. They also tend to start growing 10 years after the radiation is given, so you usually won't see those tumors for a little while. The other thing to do, because if you are at risk for strokes, you want to be as healthy as possible and decrease any other comorbidities. So you want to have a low cholesterol, you want a low blood pressure, you don't want to be sedate, lead a sedentary life and be overweight. Those can put you all at risk for stroke in their own right. So if you add that to a patient who already has a slight increase, who has an increased risk of stroke, that can cause problems. So those are things in just maintaining a healthy lifestyle.
That's great. You must have read ahead in the questions because someone was asking about diet and nutrition. So good job.
Thank you.
Cross that one off.
Okay.
Someone is actually on the webinar from India, which that just shows you that how important these are from people who can come from anywhere and listen to you anytime, any place. And they're talking about their younger brother is diagnosed with a DIPG, and he's showing a good response to radiation and chemotherapy, and wanting to know about any advanced treatment protocols that they might explore. Now, it's difficult there in India, not knowing what's over there in India. So what protocols, should they look to come here? Or is it more likely they should stay there? And what could they even ask over there?
Right.
Do you have any comments for that?
So a DIPG is a lot different than a low-grade glioma. So unfortunately, a DIPG is a very aggressive tumor in children that involves the brainstem. And the best treatment they're getting right now, which is radiation, just to the DIPG. We're doing some studies looking at molecular targets for DIPG, but right now there's not a great treatment for these tumors except for radiation. So you could go anywhere in the United States or Europe, but all of the things that we're using to treat that tumor are experimental. And nothing right now has been effective at treating a DIPG. So you can just keep posted. If you want to send us your information, we're happy to take a look. But really, there's no great therapy in the United States or Europe or Canada to cure a DIPG.
Thank you so much for answering that. I'm sure that means the world to them, just to be able to reach out and get an answer. Does a patient that tests positive for BRAF mutation have a better outcome than a patient that doesn't have the BRAF mutation?
That's a great question. We're trying to figure that out right now. We still think that patients who have mutations still do well, but we're just getting all that information together. That information would not be in that SEER database, so we're doing it as a collaboration with other centers around the U.S. and looking at their outcomes and their treatments. So the one thing just to know is pilocytic astrocytomas typically have the BRAF duplication, and diffuse astrocytomas and gangliogliomas tend to have the BRAF mutation. So the nice thing is they do separate out, so it's probably going to be similar to this graph here, where the pilocytics tend to do a little better. And we also haven't treated those mutations with specific drugs, so I think the jury will still be out on that. But I still think overall everyone does quite well.
Again, good news. Let's see here. We only have time for maybe one or two more. What are some new treatments being used to treat PLGG, and what are the side effects associated with those treatments?
So these drugs that I was talking about, these MEK inhibitors or BRAF inhibitors, are and the mTOR inhibitors are the new drugs that are being used to treat pediatric low-grade gliomas. Again, for at least getting the BRAF inhibitor, the V600E, we need to know your BRAF status. So we won't treat you unless we know that you have the mutation itself. The side effects so far have been fairly minimal. Some of the side effects associated with the BRAF mutation drug have been rash. It can cause some renal dysfunction, but that's short term. There is concern that if you're on some of these medications for long term, it can cause some cardiac issues, or, and these are more from adult data, And then the MEK inhibitor can also, the BRAF inhibitor can also cause skin cancers. But the interesting thing is if we combine the BRAF inhibitor with the MEK inhibitor, we decrease the chance of skin cancers. And a lot of that time, if you stop the drug, those symptoms go away. So we're still learning about these medications because they haven't been around a long time like some of the other ones. So I can't tell you if you were on it for 5 or 10 years or if you had it 5 years ago, how would you do? Because in pediatrics, we're just starting to test them.
Okay, and I'll fit one more question in here. Someone's child had 2 total resections, one done at 8 and one done just a couple weeks ago. What is the chance that it will recur again, even with 2 total resections?
The chances are low if you had a gross total resection. The fact that they're older now sometimes too puts that risk even lower. You know, the nice thing again is the likelihood if it grows back, it's going to grow back locally, and it again usually does not transform into something more aggressive. So the chances are quite low. You know, if I had to guess a percentage, it's going to be less than 20% chance of coming back. But even if it does come back, the surgery would still potentially be another option, and the likelihood of it transforming into something more aggressive is very low.
That's a good answer to end on. So that's all the time for the questions that we have today. Thank you so much, Dr. Manley, and everyone for asking a lot of really good questions, and I'm sorry we didn't get to everything. For more information on immunotherapy and other brain tumor-related topics, we have healthcare professionals here that can provide you with support or help you navigate our sites to help you answer the rest of your questions. You can just give us a call at 800-886-2282. So we're just going to pause for the moment, and we are going to end our recording, and then we're going to share some